Good afternoon. Thank you for joining us today. My name's Teresa Miller, and I have the privilege of serving as the Secretary of the Department of Human Services. At the end of June, the Wolf administration issued an order to personal care homes, assisted living residences, and intermediate care facilities licensed by the Department of Human Services, requiring universal baseline testing for all residents and staff in these facilities by August 31st, yesterday. This was an extension of a baseline testing order issued for nursing facilities overseen by the Department of Health at the start of June. In July, the Department of Health reported full compliance with this order, and today we are proud to announce the same for the nearly 1,400 personal care homes, assisted living residences, and intermediate care facilities licensed by DHS. All have completed baseline universal testing for residents and staff. Through this effort, more than 127,000 residents of long-term care facilities were tested, setting a foundation of assessing the presence of COVID-19 for the nearly 2,000 facilities covered through these orders. But while we are proud to mark this accomplishment and are grateful to our long-term care network for recognizing the need for and value in this baseline testing, we know this is just a step in our continuous work to protect vulnerable residents and staff of long-term care facilities from COVID-19. COVID-19 is still a very real threat, but we are better positioned now as we head into the fall and flu season with the knowledge and experience that we've gained in the first 6 months of this pandemic. We must learn from experiences of the last 6 months and continue to strengthen prevention and response efforts as this pandemic evolves. Protecting medically fragile and vulnerable residents of long-term care facilities requires constant vigilance, and this universal baseline testing is a critical step in allowing these facilities to know the status of COVID-19 in their facility, and that will inform mitigation efforts and steps necessary to keep residents and staff safe as we move into the fall. I'd like to take a few minutes to thank and recognize the health system partners who were invaluable in this testing process and made it possible for so many facilities to meet this requirement ahead of the deadline. The Regional Response Health Collaboratives, or RICs, have worked tirelessly since they were selected just 6 weeks ago to support facilities as they completed this universal testing goal. The RICs replaced the Education Support and Clinical Coaching Program, which was a voluntary program that we created this spring in providing operational, clinical, and administrative support for long-term care facilities as they protect their residents and staff from COVID-19. This network builds on the Education Support and Clinical Coaching Program's successes and continues to support long-term care facilities across Pennsylvania as they respond to COVID-19 by assessing preparedness to properly respond to a COVID-19 outbreak, support with best practices in infection control, and implementation of other COVID-19 mitigation efforts, testing and contact tracing efforts, and on-site and virtual clinical consultations. Health systems assigned to each region are the Thomas Jefferson University and the University of Pennsylvania in partnership with Temple University Hospital in Southeast Pennsylvania, Geisinger Clinic and Lehigh Valley Hospital in Northeast Pennsylvania, Penn State University in South Central Pennsylvania, Geisinger Clinic in North Central Pennsylvania, UPMC Community Provider Services in partnership with Allegheny Health Network and the Jewish Healthcare Foundation in Southwest Pennsylvania, and LECOM Health and UPMC Community Provider Services in partnership with Allegheny Health Network and the Jewish Healthcare Foundation in Northwest Pennsylvania. These health systems are providing direct 24/7 support to long-term care facilities across Pennsylvania and are doing important work to help prepare for and implement policies and procedures that can help mitigate COVID-19 outbreaks at these facilities. This network is designed to be a peer support system for the long-term care system. The RICs are not regulatory authorities. They exist to support an environment where facilities and health systems can work together to assess, strengthen, and implement preparedness plans and mitigation strategies that will keep staff and residents safe amidst this pandemic. Long-term care settings offer different levels of care, and less acute settings may not have on-site clinical support necessary to navigate the pandemic. The RICs help fill this role by being an accessible support that can triage issues as they arise or be a trusted source that long-term care facility staff can turn to for questions or concerns. In the 6 weeks since the RICs have been in place, they have worked quickly to be supportive and responsive to needs of long-term care facilities around Pennsylvania. RICs are completing initial on-site visit and readiness assessments for facilities in their region, supporting call centers that are available 24/7 for technical assistance and clinical support, assisting with PPE supply and fitting, and other needs that arise as facilities navigate this pandemic. When a RIC engages with a facility or is called in to help with a concern, these are called missions. Missions could range from assistance with testing, assessing a facility's preparedness, staffing support, rapid response, PPE support, fit testing, and questions or concerns requiring clinical consultation. Since launching, the 6 RICs have been assigned nearly 3,000 missions, primarily covering testing, consultations, facility assessments, and support with PPE. The RICs have made 59 total rapid response team deployments, with 52 of those completed at this time. This is where a multidisciplinary team goes to a facility to assess and stabilize the situation when an outbreak is occurring in a facility. More than 650 on-site facility visits occurred by the RICs as they work to assist long-term care facilities. And the RICs call centers have received more than 500 calls to assist facilities with universal testing, staffing support, educational support, PPE, and testing kits. Their reports are among the data that we're receiving regularly from the RICs that help elevate issues that facilities are experiencing to help inform response and support efforts moving forward. The RICs work closely with staff at the Department of Human Services and the Department of Health and the Pennsylvania Emergency Management Agency to report on experiences with each of the long-term care facilities they're working with and elevate potential issues or areas of concern so resources and supports can be directed. COVID-19 is an evolving challenge. The steps that long-term care facilities are taking with the support of the RICs, Department of Health, Department of Human Services, and PEMA will help to strengthen preparedness and be better positioned to respond to cases and outbreaks if they occur. But cases and outbreaks may still occur. This effort is about prevention and preparedness. We cannot declare mission accomplished, and we are urging proactivity as we navigate the uncertain weeks and months ahead. And we've received really positive feedback about this support network so far. One facility shared that they were extremely worried about an outbreak due to being located in an underprivileged area. And the staff and facility leadership have been carrying the emotional burden and anxiety of a potential outbreak, knowing how dangerous it could be for residents. Facility leadership were incredibly grateful and thankful for the support, and their RIC has built trust and facilitated testing and education that is helping staff feel more confident about their work going forward. We've also heard that in facilities that have received in-person education for frontline staff, those staff are feeling empowered and prepared going about their day-to-day jobs. Frontline staff providing direct care are critical in supporting residents every day, and this staff must feel supported going through their work during this very difficult time. The RICs broaden the scope of support we can provide to these facilities, and beyond their clinical and infection control expertise, the emotional support and companionship they can provide to long-term care facilities will be invaluable as we move forward. All of us know that this spring was difficult. Unfortunately, we are not out of the woods with this pandemic, and the threat of COVID-19 is still very, very real. But our long-term care facilities are not alone in this fight. The RIC Network and the Wolf Administration are here with them. We remain keenly focused on what we can do to support these facilities as they work to protect some of our most vulnerable Pennsylvanians, and we will work through what comes next together. Thank you again for joining us today. Before I turn it over to my friend and colleague, Secretary Levine, I just want to publicly thank her and her agency. Our agencies, along with PEMA, have been working very, very closely together to provide the supports that we need for these long-term care facilities. And I just want to publicly say how much we appreciate that partnership. And now I will turn it over to Secretary Levine.
Well, good afternoon. Thank you so much, Secretary Miller. I share our thanks working with you and all of the RICs and all the collaboration with PEMA and the Department of Military and Veterans Affairs and the National Guard, really all agencies working together for these vulnerable patients, individuals in Pennsylvania. So, the universal testing for all of the long-term care living facilities has been a significant undertaking for both of our departments. And I'd like to thank your team, who has done a fantastic job at ensuring that universal testing was completed right on time. Universal testing in long-term care facilities is an essential piece of our efforts to prevent and mitigate future outbreaks of COVID-19. Now that we have completed 100% of the testing in the skilled nursing facilities that we license and the personal care homes and other facilities that you license, we know and we now have a baseline to know the true scope of how the virus has impacted residents and staff at those facilities. It is because of this testing that we have actually been able to identify cases and outbreaks earlier and provide resources to facilities to help mitigate and deal with those outbreaks. But as you've pointed out, our work is far from done to protect residents and staff in long-term care facilities. We all have a collective responsibility to prevent the spread of COVID-19, and we must be united in that effort. So please remember that when you are wearing a mask in public, when you go out in public, indoors and outdoors, you are stopping the spread of COVID-19. When you wash your hands and you use hand sanitizer, you are stopping the spread of COVID-19. By avoiding large public gatherings and by practicing social distancing, you are stopping the spread of the virus COVID-19. And obviously what's most important for everyone in Pennsylvania to remember is stay calm, stay alert, and stay safe. We are now available for questions. Yes?
Secretary Levine, the New York Times put out a piece over the weekend about testing, talking about a potential of overinflation of testing numbers coming back through the PCR of like 90%. Can you clarify within those PCR tests the level of virus it's detecting, the threshold? Is it catching it when it's contagious, or is it catching it when it's after the contagious stage? Can you elaborate on that at all?
So the PCR test is a very, very accurate test. It is very sensitive and very specific, and it's called a polymerase chain reaction test, and it's testing for the presence of the DNA, of the nuclear material of the virus. And so in terms of the incubation period, it takes several days, but it will test for the presence of the virus itself, the DNA of the virus.
Is there a uniformity to the level of the virus that the PCR is detecting?
Well, there are many different PCR tests. I'm sure they have some variations, but we are very confident about the accuracy of the PCR tests. I mean, all the laboratories that are performing these tests are CLIA approved. They're all, the tests themselves are approved by the FDA. And so we do not have concerns about the accuracy of the PCR tests.
With that said, have you identified a threshold? Is it catching the virus in the contagious stage, or is it showing you that the folks may have had it and they've already passed it, which is why they're showing no symptoms?
So we know that there are patients who are completely asymptomatic through their entire course of having COVID-19. There are others that might not have symptoms, and then they do develop symptoms, sometimes very mild symptoms, sometimes severe symptoms. The virus, the PCR test will be detecting the presence of the virus, whether symptoms are there or not. So if the patient doesn't have symptoms, you can still detect the virus from the test, and if the patient does have symptoms, you can detect the virus from the test. And it's a very, very sensitive and specific test. Yes?
You've completed baseline testing in care facilities. I know in the past you talked about trying to ramp up complete testing for the population, especially with schools opening. And also I believe that according to the Johns Hopkins list, we are at the bottom of the 50 states in testing per capita. What is the plan for testing outside of nursing homes?
Sure. So we're still continuing to work to expand our testing capacity. We now, on average, are testing 22,600 patients every day. We get those test results back every day, and we need to expand that more. I think that the new antigen tests, which are different than the PCR tests, these are testing for the surface proteins of the virus, I think will be a big help in terms of our expanding those point-of-care tests. The CMS, the Center for Medicare and Medicaid Services, will be sending those testing platforms, the machine, to all of the nursing homes in the state, not the other facilities regulated by DHS, but CMS is sending those to the nursing homes. Only a dozen or more have received it so far, and we'll be working with them, but eventually they will be receiving those test kits, and I think that's going to help our retesting protocols of staff and residents that are necessary really, really, really well. I think that as we expand that testing, we had a press conference with OraSure a couple weeks ago. That's exactly the type of tests that they are developing. We're hoping for those tests by the fourth quarter of 2020, and that will be a simple nasal swab that you don't even need a machine for. That can be done right at the bedside or right at the tabletop, and I think that's going to be able to expand our testing. We do not have the ability to test every single person in Pennsylvania, that type of population-based testing, but it's going to be those rapid antigen tests that allow further expansion of testing.
Can I ask, is there a specific group that you are going to focus on next as a vulnerable group?
Well, we want to expand testing in other vulnerable communities. That's really important in terms of health disparities. So we want to make sure, for example, that minority populations have access to testing, African-American populations, Latino population. We had a press conference last week with the Latino Connection. I have personally spoken with the Pittsburgh COVID-19 Black Coalition about expanding testing in collaboration with Dr. Bogan, the health commissioner in Pittsburgh at FQHCs, federally qualified health centers. So I think that it's really important to be able to expand testing to minority communities. And so we'll be emphasizing that as well. Yes?
Assuming that the point of universal baseline testing is to kind of gauge where there's COVID that we don't know, right? Can you say how many facilities you actually discerned had it that didn't know they had it?
So I don't have a specific number at my fingertips, but there were a number of facilities, both. We can try to get you some more granular information about that, but we know that there were nursing homes and then also other long-term care facilities that had individuals that were asymptomatic, both staff and residents, that were detected using this testing. Would you like to further respond? Sure.
At least for our facilities that just completed their testing, yesterday was the deadline, and so we had 1,400 facilities that each submitted separate paperwork. So we will make this public. Right now, we're just going through 1,400 different documents to figure out what that number looks like. So we do anticipate publicly reporting that as soon as we can kind of collect it all and put it in one place.
And then just as a follow-up, answers, there must be retesting planned, and the way you had described it previously was if we found it the first time, then we would kind of test more. Can you explain sort of where things stand as far as retesting in facilities?
So there is some specific CMS guidance that came out last week about retesting, and so we're going over that, and then soon we'll be putting out to our facilities the retesting guidance for the skilled nursing facilities, the nursing homes that we regulate, and I believe Secretary Miller will be doing the same for the facilities that she regulates.
But you can't shed any light on what that guidance is.
The guidance, I mean, there's specific guidance in terms of testing staff that depends upon the prevalence of COVID-19 in the counties where they're located. So what we have said all along, and this is born to be true, is that the prevalence of COVID-19 in any of the facilities that either of us regulate is directly proportional to the prevalence of COVID-19 in the counties where they're located. And so there are retesting protocols that depend upon what that prevalence is. Yes?
So now that you have the data, you've tested everybody once, right? Nursing homes and long-term care facilities. Is there anything we've learned, or you still have to go over the numbers to pour over it? Is there any aha moment about this disease as it pertains to those facilities?
I think that what we've learned is exactly what I've said, is that it is asymptomatic individuals, asymptomatic staff who are courageous and brave to be working in those facilities, helping the most vulnerable among us, who unwittingly bring the virus into the facility. They have no symptoms, but through the universal screening testing, we have detected staff that are positive. And then, of course, those individuals are isolated, and they're at home, and they're not in the facility. But we have detected that, and so it validates what our academic partners have been saying all along, is that it's asymptomatic staff that bring it into the facility through no fault of their own. And by the testing and then the retesting protocols, we're going to be monitoring that and working to prevent that.
I just ran the numbers for today, and we're still at 67% of the deaths are in those facilities, which ranks us higher than most other states. Some are higher, but we're higher than most. Why is that? Have we learned anything? Obviously, we're now 6 months into this.
Sure.
As to why that's where a majority of those deaths tragically continue to happen.
So what many states, in fact most states, have found is that the majority of deaths, and the specific numbers, are among seniors, particularly seniors with chronic medical conditions, which is exactly the population that's in the congregate settings that we're discussing. The most ill are in nursing homes, skilled nursing facilities, but other very vulnerable individuals are in the other facilities, personal care homes and assisted living, and other facilities that are licensed by the Department of Human Services. Some other states saw less increases in numbers and death in the spring. So I'll give you an example, Florida and Texas. But because of the significant increases that they had this summer, they also have seen significant increases in terms of the number of patients, residents with the illness, and tragically the number of deaths in these facilities. It is the most vulnerable among us for this very dangerous respiratory virus, which is why we're going to all the different programs that we have outlined, the RIC programs that were outlined by Secretary Miller, the testing and then retesting protocols to try to prevent and mitigate the spread in these facilities.
And my last question, Department of Justice obviously was announced last week is looking into the nursing home situation, and they're not going to comment on the specifics there, but in your looking at what has happened over the last several months, have you learned that, oh, maybe we made a mistake here, or maybe, so for the next time, hopefully there isn't a next time, but if there's a next time, we can react more quickly in that to those populations?
So, I cannot comment upon the Department of Justice letter, and we're reviewing its request for data. I think that there are two big differences, which have been outlined today, of what we're doing now. One is that we're doing this testing. That testing was not available anywhere in the country in March and in April. I mean, in March, we were able to do the first tests in Pennsylvania at the beginning of March. And in April, there was significant shortage of testing supplies, testing reagents, and so we were not able to do the type of testing that we have just done, to detect those asymptomatic staff that are bringing it into the facility, to detect patients who might have contracted it and are asymptomatic, and then immediately isolate them and do cohorting within the facility. So we did not have that capability then. We do have that capability now. The other is the RIC program that was being discussed by Secretary Miller, working with these fantastic hospitals and health systems to really provide even more support than was possible in the spring now. Anything you'd like to?
Okay. Great. Todd, last question.
Yeah.
Secretary, in reviewing the most recent death data as of August 28th, the number was 7,655 deaths, and then there was a note in the report of 37% of those deaths, roughly 2,800, did not have comorbidity data. Is there a reason there's a lag now, so many months in, of having providers get that data to you to outline if they do in fact have a comorbidity?
So the death data comes in a different way. So it does not come from NEDS. The death data comes from the electronic death reporting system, and it takes time to be able to investigate and get the information such as comorbidities on all of those patients. So it does take time to be able to collate that data, but through the electronic death reporting system and the different information, sometimes chart reviews and things that have to happen to get all that information. But we're always working on it.
Thank you, Secretary.
Great. Thank you so much.